This week's focus is on multiple sclerosis. So many of you may already know a little bit about MS. Some of you may not know anything about MS, but MS is a condition that I really like to make sure I focus on when I'm teaching pathophysiology with exercise, simply because there are so many people in Ohio that suffer from MS, and understanding how exercise needs to be balanced and some of the specifics I want to make sure we go over. Simply, what is MS? It's a progressive degenerative inflammatory disease. So it's a disease that originates in the central nervous system, and it involves the brain, the optic nerve, and the spinal cord. So very different than the chronic diseases we so commonly focus on. I have two very interesting links that you have access to when you take a look at the slides. I would encourage you to take a look at those links. So again, it's disease that affects the central nervous system. It's progressive. As it progresses, body functions, many different body functions are going to come into play. So that's what we're going to be looking at. So it is classified as an autoimmune disease, and what's happening is the demyelination is kind of what we call the pathophysiology. So characterized by nerve demyelination, plaques known as the word sclerosis in the brain and the spinal cord. These develop into permanent scars, and the more plaques or the more sclerosis along those nerves impair transmission, and over time body weakness, aches, pains, fatigue, motor function delays, motor function control begin to be hindered. When you're looking at the scope of the disease, there's about 2 to 2.3 million cases worldwide, and interestingly, it's based on northern latitudes having higher prevalence. So the initial diagnosis can be right the age that probably most of you are right now, between the ages of 20 and 50. There seems to be more women affected, 2 times the rate as men. Susceptibility is very complex. They believe perhaps it could be a genetic predisposition, it could be based on infectious environmental factors. Really don't have a direct pinpoint as to the cause. More than 50% end up over time being classified as disabled within the first 10 years of being diagnosed. So you begin with diagnosis, and then again it's progressive disease, and by 10 years later disability happens, and a high cost of medical bills. So as we spoke about latitude, latitude is something we don't often speak about in our world with chronic diseases, but again, this is not a chronic disease, and interestingly, MS has been linked to latitude. So here on this map, we see a greater risk in what we call temperate zones versus tropical. So take a look at the red and the oranges, right? So this is these are the greatest risk based on latitude, and again, it's more of our temperate zones. So looking at cases in the United States, northern cases more so than southern cases. When you look globally, right? In the United States, Canada, Alaska, when you look back over here into, Europe and, different countries. So the latitude is a really important thing to look at. So risk factors, again, as I mentioned, women with MS, the ratio is definitely higher among women. 15% have more than one family member or relative with MS. When you look at identical twins, 1 in 3 chance of also having the disease. So how does it work, right? Remember, it's the central nervous system consisting of the brain and the spinal cord. Fatty substance we call myelin. And that myelin is a coating. We need myelin sheath. Myelin sheath insulates the nerves. It helps with transmission of nerve impulses between the brain and other body parts. And as the myelin gets broken down, right, the myelin sheath becomes ruined, and sclerosis and plaque ends up, the connection becomes delayed. So when you see these impulses or messages being delayed, that neuron that's firing, right, that myelin sheath is broken down, and that's what's really controlling the ease and the smoothness of our movements. So as we end up with demyelination of the nerves are firing this impulse, and it's leading to miscommunication, delayed communication, and what causes neurological symptoms. So these neurological symptoms, such as abnormal sensation, vision problems, and weaknesses. Many times people begin having these neurological symptoms and not too sure why. These very strange symptoms begin. They often begin in small doses. don't really have a rationale. Someone may be young and healthy when this happens, remember, in their 20s. So there's no proven reason as to why bodies' immune systems begin to deconstruct. Many research and scientists believe it's a combination of both genetics and environmental exposure that is the cause. So the danger is that this attack on the immune system, right? So this attack on our central nervous system, these axons, our demyelination is happening. We end up with permanent loss of function. Impossible to predict how each person will be diagnosed or how long it's going to take for those symptoms to end up surfacing enough to be an actual MS diagnosis. It can be devastating. Remember, as I mentioned, by about 10 years, let's say you're diagnosed in your 20s, within 10 years later, 50% of the people are diagnosed being full-blown disabled, being unemployed, high cost in healthcare costs. So the process is initiated by these autoreactive T cells that they initiate the immune response against the myelin. They end up entering and crossing into the blood-brain barrier and begin demyelination. The myelin sheath begins deteriorating, plaques result, and now axonal destruction is happening, so that connection is being impaired. So impairment of nerve conduction leads to symptoms and inability to perform activities of daily life. 4 major clinical courses of MS exist. We'll take a look at those, but this is kind of that autoreactive, a photo to help you. The autoreactive T cells initiating the immune response against myelin, resulting in central nervous system demyelination. Again, associated with MS, these T cells are autoreactive. We don't know the mechanism for how this happens. We do know they enter the blood-brain barrier and into the bloodstream, and then the outcome is again muscle control. Neurological symptoms. Here are the 4 different types of MS. Clinical courses are either relapsing remitting, right? So characterized by disease relapses with either full recovery or a deficit after recovery, so no progression of disease symptoms. Primary progressive is disease progression from onset with infrequent plateaus. Secondary progression begins as relapsing remitting but progresses, and then the progressive relapsing. So when we meet a patient with MS, they're usually going to be able to tell you which of these clinical courses they have. So it's really kind of common knowledge. It's not something that you're going to just get right away, understand these 4 differences, but they're really based on symptoms. Frequency of MS. So 85% are diagnosed with what we call RRMS, relapsing remitting MS at onset. Untreated, about 50% of the people with this will begin, if they're not treated, it'll evolve into secondary progressive MS within a decade of the initial diagnosis. Another 15% are diagnosed with PPMS, primary progressive at onset. So again, these are the different types. So if you take a look at, what are these types and then how do they evolve, it depends on age of diagnosis, symptoms, are they being treated. So again, what causes MS? We really don't know. Associations is what has been published. So sex, racial group, family history, environmental exposure, latitude, socioeconomic status, migration, people who immigrate to different countries and different climate zones at different ages, and basic infections. The symptoms that I want you to be aware of. So these are really important. So what are the symptoms that someone presents with MS? Muscle weakness, symptomatic fatigue, numbness, visual disturbances, walking, balance, coordination. Interesting, bladder dysfunction. So remember, you could be in your 20s or 30s and you start losing bladder control, right? That's a flag that there's some odd neurological symptoms going on. Depression, emotional changes, sexual dysfunction, pain. There's these symptoms. Signs, optic neuritis. So optic neuritis is inflammation of the optic nerve. It's very painful. Nystagmus, again, eye, vision problems. Paresthesia or paresthesia is abnormal thermal sensation. So how you would define paresthesia is tingling, prickling, chilling, burning, very numb sensation on the skin. So this is abnormal skin sensation or dermal sensation. And you really don't understand why you're having these tingling sensations. The manifestation of paresthesia is maybe transient, or it may just be chronic, and dozens of different underlying links. Spasticity of the muscle is another big one. So when you're looking at the clinical considerations, Very common early indicators are vision impairment. So again, optic neuritis, nystagmus, motor difficulties. So paresthesia, um, spasticity, difficulties walking, balance coordination, memory, cognition problems. So some have cognitive changes while others may be more what we call ataxia, which is kind of lack of balance, hemiparesis, depression, visual symptoms. Patients with MS can present with facial palsies, affecting a lot of voluntary movement. Again, as I mentioned on the last slide, urinary retention incontinence. Disease progression can either be continuous or it can be intermittent. So when you look at clinical features, right, profound fatigue is oftentimes fatigue and just odd symptoms, that numbness, the tingliness, that doesn't really match with oftentimes where someone is in life, right, their age and what they're usually doing. Motor fatigue, which develops with continued activity. This is an important one. Marked decrease in heat intolerance. So very uncomfortable in heat. They really cannot tolerate the heat. Blurring vision can occur in one or both eyes during exercise. So as they exercise, their body becomes warm. And we oftentimes see during exercise blurred vision. Optic neuritis, again, painful blurring vision loss. It usually begins and can last for weeks on end. It's very painful. Weakness that usually starts in the lower extremities and works its way to the upper extremity. When we use the word spastic paresis, partial paralysis of both legs, it's characterized again as progressive weakness or spasms in the leg. So that's what we call the spastic ataxia syndrome. Ataxia, as I mentioned earlier, a neurological sign consisting of lack of voluntary coordination or movement. So ataxia is someone who just looks funny when they're walking, kind of that drunken stupor. Weakness, fatigue, as I mentioned again, sensitivity to temperature changes, visual disturbances, spasms, bladder control, speech changes, abnormal eye movements. History and physical exam is our indicators. Again, we don't really have a direct way that physicians are diagnosing MS, but they're going to review all medical history and medications, look at balance, flexibility, strength. The goal is to categorize definite MS, possible MS, or then if they have MS, one of the categories. So there's not an easy one test for MS. It's a battery of lots of things: medical history, neurological exam, MRI. The MRI can look at distribution where those lesions are, the plaque, right, the demyelination that's happening that's causing plaque. They can look at sensory stimulation, visual, auditory, somatosensory. They can also take a look at what is in the cerebral spinal fluid. So looking for any type of odd protein levels, immunoglobulin levels, blood tests to rule out other diseases. It's a very time-consuming process to get diagnosed. Symptoms begin small: vision, tingling, fatigue. Years usually go by before they actually have a full-blown diagnosis. We have no cure for MS. The goal is to reduce or slow the effects of MS, treat the symptoms. The only FDA-approved medication are corticosteroids to reduce the inflammation. Again, I'm not going to ask you to know medicines. You're going to look them up, but really you want to make the person as comfortable as possible. So they're going to be on a host of different medicines. What we want to get at is movement. The important thing about physical therapy, occupational therapy, speech, cognitive specialists. Some people are using Chinese medicine, relaxation, yoga, Tai Chi, acupuncture. Let's get to the exercise. So as early as 20 years ago, or as short as 20 years ago, many healthcare providers believed that we needed to, or physicians would say, no activity for anybody with MS. Restrict all activities, even bed rest. The philosophy was based on a study that was done way back in the 1950s that included what they call a hot bath test, right? A bathtub full of hot water. And individuals, these MS patients, were immersed into the bathtub of hot water, and what they noticed is that once you put somebody's body in hot water, they demonstrated increased symptoms, and therefore it was assumed that anything that increases core body temperature will make things worse. So therefore they felt exercise increases your body temperature, your core temperature, therefore don't let people move. Keep them stationary, sedentary, bed rest. We don't want any type of stress on the body. They realized that that was an old perspective. That is wrong. What they now know is that increased activity and moving and rehab and exercise are major reasons why you can delay and improve the quality of life of someone with MS. So we really hope that we can get someone with MS to have normal life expectancy, but we really need increased activity and movement in order for this to happen. So people are no longer put on bed rest. We know that inactivity is not going to be good for them. We know both mentally and physically. Extensive research has been done looking at deconditioning of MS, and we are not putting people on bed rest anymore. Exercise testing for baselines. Look at what they're able to do. Look at their baseline stress. We need bottom line criteria to write a prescription. Cycloergometer, if they're walkable, if ambulatory, we can have them walk. If walking is not safe, we're going to use a treadmill. I want you to be aware of the word electrical fans, right? You need to make sure that if you're training somebody with MS, that they are high risk for overheating, and as the heat increases, these symptoms increase. So you want to be able to use an electric fan to cool, surface cooling, fluid replacement, keep the room nice and cool. Exercise environment should already be kept at 68 or below. Use low level of intensity protocols because they're mostly deconditioned. Watch for what we call attenuated blood pressure, which means a blood pressure that does not respond with increasing workloads. Why? Because of the central nervous system, right? Delayed central nervous system, especially if they have this thing called autonomic dysfunction, which is usually what our MS patients have. Autonomic dysfunction, right? That autonomic nervous system is damaged. It's not communicating very well. So heart rate and blood pressure often are blunted. So standard testing, 1 RM can be used, but really low weight. Flexibility, goniometers, really be aware of spasticity in the muscle, tightness and rigidity in the muscle. Avoid embarrassing situations, so remind the person to go to the bathroom, take a pee before they exercise, because when someone is incontinent, they can't feel that they have to pee, right? That's what this neurological symptom causes. You want to make sure they empty their bladder before you start exercising with them. Keep close records on how they're doing. So balance tests, workloads, chart everything, avoid overheating as I mentioned, keep temperatures cool, monitor fatigue. When you're looking at balance, we oftentimes use the Berg balance scale. So this would be in a great time if we are not in an online remote setting to take you to the lab and teach you some of the different balance tests. So the Berg balance, anyone who's been in a clinic has probably seen the Berg done. It's a battery of small skills, and you score the patient between 0 to 4 on each task. And depending on their overall score, if their score is less than 45, it means they're a high risk for falling. So assessing someone's balance using the Berg, and you all could administer the Berg on your own. So if you have a client that's referred to you with MS, you're going to want to do the Berg test and see what their risk for fall is. If they have a high fall risk, I need you to really be looking at helping for finding exercise, neuromuscular exercise that's going to improve balance. Again, exercise testing, depending on if they're ataxia, what their coordination and balance is. If you're going to do a treadmill or a cycle or a treadmill, all of those things, you want to watch blood pressure, temperature, all of those things I keep saying, right? You really want to watch all those things. Our goal is to have them stay active, activities of daily living, general health benefits to reduce the risk of diseases, deconditioning. There's no specific exercise training guidelines, but what I want you to be aware of are the clinical implications. So read my clinical implications and special considerations. So remember that they are definitely deconditioned cardiovascularly. Their blood pressure is going to be blunted or not respond like it's supposed to. Their heart rate is going to be the same. This word thermal regulation is what I've been mentioning, right? Their body is unable most to regulate core temperature, so they overheat. And as they overheat, their symptoms are going to increase. The optic neuritis, nystagmus, all of these things can happen. With muscle spasticity, poor flexibility, muscle fatigue sets in, poor flexibility, really being aware of a lot of the small part pieces in the exercise program is really important. So cardiovascular strength, range of motion, neuromuscular balance. 5 days a week, 30 minutes, you're probably going to have to start these clients in small bouts, 10, 15 minutes at a time. Stationary cycling is ideal because of balance and lower extremity weaknesses. Progress based on the person's heart rate response. Take a look at how they're responding. Resistance is really important for mobility and independent living. Do the resistance at least 2 times a week. Elastic bands, dumbbells, 8 to 12 repetitions, all of those things. Balance programs. Many of you are familiar with how to do balance programs, right? I know a lot of you are in range of motion and exercises. Exercises to improve range of motion, but really be aware of what needs to be done that is for your deconditioned population. When you're looking at specific prescription recommendations, again, balance, use a handrail, regulate temperature, watch for fatigue, make sure their bodies are staying cool, be aware of thermoregulation, be aware of what we call unilateral weaknesses, balance issues, fatigue, recognize muscle imbalances and address those. So with the resistance training, take a look. Are there low extremity? Commonly, that's where you see the weakness first. You see a lot of young MS patients having to rely on a cane or a walker, and they may only be in their 30s, right, because of that weakness that sets in. Eventually, a wheelchair is very common. So, be aware of how to teach somebody how to stretch in a chair. Many of these people are not going to be able to get down on the floor and get back up, so being smart about what you're prescribing. When you're looking at impairments, again, there are areas which have been shown through research to be modifiable through exercise and rehab exercises. It's really empirical research. We know that impairments such as pain are modified by exercise, so keeping people moving, even though they're weak with a lot of fatigue, is really beneficial. Saying it again, thermoregulation, right? So if I ask you what are the common new things that you learned in MS, it's probably going to be thermoregulation, right? You need to ask them what kind of clothing are they wearing, stuff that's breathable, have a fan on them, have them stop and rest, hydration for fluid replacement, control the room, electric fan, pre-cooling, so a damp cold towel, removing layers of clothing. They're going to hit fatigue earlier than the healthy population. And really, really watch for balance. And the thing about this lecture is, remember, MS is diagnosed oftentimes between the ages of 20 and 50. These people are young, right? So I don't want you to think about this aging elderly. This is young people. So you need to be creative and sensitive to a fact that just a few years ago, this person was maybe on a college campus with no impairments, and now MS has set in and things are progressing pretty fast. So there's lots of, adaptive techniques, gloves, and ways of helping their feet to stay on pedals, and ways of really bandaging and wraps that's innovative. Resistance training guidelines, sweating response. So what you find with people who have thermoregulation is they get hot and overheated, but they're not able to get that sweat response going. So we want to avoid from letting their body get that hot, because when you get hot, your body starts sweating, and that sweat helps to maintain core temperature. With MS, thermoregulation is not happening, impaired thermoregulation. So as they get hot, they're not sweating, and all these symptoms begin increasing. Swimming is a really good modality. It's great because it really helps with anyone with balance problems, but the pool cannot be too cool or too warm, right? So you want to find a cooler pool. So example, most college campuses, the pool is set for the swim team and it's freezing cold, and that's ideal, right? Versus a therapy pool is usually going to be too warm for the MS patients. So a little backwards. Sensory deficits, tactile proprioception, be aware of all the ways that we can help train them. Be aware, as I mentioned earlier, with seated exercises for flexibility. Watch their gait if you know how to analyze gait. What we oftentimes see with these muscle imbalances, muscle weaknesses, and tightness of muscle groups, you oftentimes see during the swing phase of the gait cycle, the foot drop foot happens a lot. So cardiovascular is an important thing for exercise capacity. Resistance training is really important for dynamic strength and power. Balance, what are some appropriate balance exercises that you want to be aware of, and different ways that we can do balance training. Overall, we have research. These are showing you different research that's been done to say MS patients should be doing cardiorespiratory, muscle strength, muscle endurance, flexibility, balance, and being aware of their body composition. Morning exercise is going to be best because circadian temperature and the body temperature is going to be lowest in the mornings. Surface cooling is very effective. That's a damp, warm, cool towels or washcloths. Begin exercise early while they're still healthy. Don't wait for 5 years into MS when they've lost muscle and strength. So begin early. Perform activity to their limit of wherever the disability is. Maintain low levels of exercise, so don't progress them too fast. Again, morning exercise, surface cooling, suitor motor response, that is your thermoregulation, right? So at what temperature we oftentimes see thermoregulation beginning to happen. So when we talk about absent suitor motor response, it's when the body is not letting sweating to happen. And then spastic paresis, lower extremity weakness, I mentioned that already. Spastic ataxia, movement coordination is another one. In conclusion, there are no definite guidelines for me to give you. All I want you to know is that evidence 100% exists. I have myself trained so many people with MS. You're slow, you move slow, you have to be understanding to symptoms, but it is life-changing. The one lady I have worked with begun on a walker. She was in her 30s. She ended up on a walker, progressed to a wheelchair, went backwards. We got her out of the wheelchair that she was completely over months and months and months ambulatory and was able to walk a 5K independently on her own. So you see how that kind of roller coaster of symptoms, right? Walker to wheelchair to being able to go on her own. She was gaining weight. She was ended up on unemployment or disability because she couldn't get up in the morning and get to her job. Her symptoms were so severe. Depression sets in. Exercise, right? Really, really important for you to realize your role in changing MS. Here in town, we have a clinic called the Oak Clinic, OAK. Oak Clinic down in Green, I think that's 619 Road that it's on. Fabulous place to go and observe. And they do exercise classes, they do yoga classes. The goal is to get people up and moving.